say yes, they can hear me.
Yes, I can hear you now.
We can.
Thank you.
Oh, great. Good morning or good afternoon to everybody, depending on which part of the world you are joining us from. My name is Nonhlanhla Ngwabe, and I'm with ICANN, and I would like to welcome you all and thank you for joining us for the first time. If you're joining us for the first time, or again, if you've joined us for our previous webinar series, welcome to webinar series 6, and this is week 4. Just a note to all the participants that if you are attending of this webinar series, you will only get a certificate of attendance if you've attended 4 to 6 of the total number of the series that we've been running. And if you also stay for at least an hour or 60 minutes, then you will receive a certificate of attendance. Our webinar series addresses infection control, specifically looking at leadership and management. And today we'll be addressing the behavior change in our specialized units. We're talking about areas like theater, the intensive care units, emergency rooms, looking mainly at the layout and achieving the ideal or the best possible way to set up. Looking, of course, around infection prevention and control. Please ensure that you keep yourselves on mute and that your cameras are off as well. This will actually ensure as well that we can provide you with the best quality of the presentations that will be coming up for this series. If you do have any questions, please put them in the Q&A box or post them in the Q&A box. Do not post them on the comment section because we'll not be able to respond to that or attend to them as well. And then if you've also got questions and you're raising your hand, we cannot attend to that as well. So put everything in the Q&A box and we'll attend to it after all the presentations are done. With that out of the way and without further ado, I'd like to introduce somebody from the Africa Center for Disease Control who's going to give us an update on COVID's status in Africa. Thank you.
Thank you. Hello, everyone. I'm Chimwemwe from Africa CDC, and I'll be taking you through the epidemiological situation of COVID-19 as of today, 31st March. Susan, if you can assist in projecting the slides, please.
Okay, 1 minute, please. Sorry, my computer's stuck, so I'm waiting for it to open.
Let me just try to share from my side. Can you see my screen?
Yes, we can.
Okay, thank you. So just to give a quick overview of the global situation, to your left is the distribution of COVID-19 cases by country across the world. The darker color indicates the countries that have reported over 1 million cases since the pandemic began in January 2020. 21 countries, including South Africa, are in this category. The panel to the right is an epidemic curve showing the trend of COVID-19 cases reported daily by the 6 WHO geographic regions. The Americas region, that's in yellow, and the European region in light green are still reporting the highest number of new cases by day. In the past AP week, over 3.8 million new cases were reported globally, and these two regions accounted for 78% of those new cases. Africa, in the dark red color, accounted for 1.8% of the new cases reported in the past AP week, and it also accounts for 3.3% of all COVID-19 cases that have been reported globally. So looking at the AP situation in Africa, all 55 AU member states have been affected. However, we do not have current information for one member state. 45 member states have reported 100,000 cases or less. The epic curve on your right is showing the number of new cases reported by day. The new cases being reported from across the continent has continued to decline in the past week, as shown by the 7-day moving average. The eastern and northern regions are currently showing an upward trend in new cases. Cumulatively, over 4.2 million cases have been reported, with over 112,000 deaths, giving a case fatality rate of 2.7%. And of the cases that have been reported, 90% have recovered. This table is showing the distribution of COVID-19 cases, deaths, and recoveries by AU regions. In the past 24 hours, over 5,800 new cases and about 190 new deaths and over 6,000 new recoveries have been reported from the 55 AU member states in the 5 regions. 40% of the new cases have been reported from the Eastern region, while 49% of the new deaths from the Southern region. The Western region has reported the highest number of new recoveries this week. This slide is showing the incidence per 1 million population per day by AU member states. So this is the distribution of new COVID-19 cases reported per 1 million population per day across the continent. We have grouped the incidence into 5 categories. And in the past AP week, 24 countries reported with less than 5 new cases per million population per day. 20 countries reported between 5 and 50 new cases per day. 3 countries reported between 51 and 100 new cases per day, while 5 countries, which are Seychelles, Botswana, Cabo Verde, Libya, and Djibouti, are reporting more than 100 new cases per million population per day. And this week, we do not have information for 3 member states, and those are Tanzania, Cameroon, and Liberia. This slide is showing the COVID-19 case fatality rate by AU member states. The case fatality rate has been grouped into 5 categories. 10 countries have a case fatality rate which is less than or equal to 1%. 23 countries have a CFR that is between 1 and 2.2%. 18 countries have a CFR that is between 2.2 and 5%, while 3 countries have a CFR greater than 5%. And these are Malawi Republic, Sudan, and Egypt. We do not have current information for one country. This chart is showing the trend of testing in Africa from February 2020 till date, whereby more than 39 million tests have been conducted across the continent, giving a test per case ratio of 9.5, which is below the WHO recommended range of 10 to 30 tests per reported case, and a positivity rate of 10.6%. The chart on this slide is showing the number of new SARS-CoV-2 tests shown by the gold bars, and the cases are represented by the red bars on their left y-axis, as well as the test positivity that is shown by the black line on the right y-axis. The test positivity is showing a downward trend overall. If we take a look at the test positivity by AU member states for the past epidemiological week, 8 countries have a test positivity of less than 2%. 16 countries have test positivity between 2 to 7%. 3 countries have test positivity between 7 to 10%. And 15 countries have a test positivity greater than 10%. This past week, we do not have lab information for 13 countries. And that's the end of the presentation. Thank you.
Thank you very much, Dr. Chimwemwe, for that informative update on the COVID-19 status in Africa. At this point, I would like to introduce Professor Shaheen Mehta, who is the Infection Control Africa Network Post Chair. She's been an infection prevention control expert for over 40 years. And some of you do know her, and some have had the pleasure of meeting her, and some have just had the pleasure of meeting her through her presentations. She has done a lot of work with different Ministry of Health for different nations around infection control issues, and she also has been working with Center for Disease Control, CDC, and the World Health Organization. Prof is going to walk us through the path of list resistance for behavior change in specialized areas, and she'll be focusing on the theater settings, especially now with COVID-19. Thank you so much, and over to you, Prof.
Thank you so much, No. I wonder if I could share my screen. Thank you, that would be perfect. Good, I can do that. I hope everybody can see it. Can everybody see my screen? I would imagine you probably can. So first of all, thank you very much for the invitation, and thank you for the very kind introduction. It starts showing after a while, when one has been in the subject for a very, very long time, that most people you meet, you've either met or you've taught. And it's a great feeling to see so many wonderful people from across Africa and the world have done ever so well after their training and also in their own lives. So I'm going to talk to you about something that has been bothering a lot of people and has been dealt with differently in high and low income countries. And the idea would be to look at the behavior change in the operating theater during COVID-19, if we can look at it in that sense. So the objective would be to know how conventional operating theaters work. And I'm afraid I have to put a little bit on your shoulders regarding the built environment in operating theaters for you to understand what we're going to talk about for the modifications related to COVID. And so how can we do these modifications in the conventional operating theaters? And of course, then we want to understand what are the most effective, evidence-based, effective IPC recommendations in the operating theaters that will make a difference. Not a whole bunch of other stuff like standing in buckets of disinfectant and spraying each other and doing all that stuff. What is actually going to make a difference in reducing transmission? And those would be areas that I choose to cover, being ventilation, cleaning of the environment, PPE of staff and patients, and managing PPE, and waste, because there's a huge waste generation issue. So the contents are basically looking at the point of care, and this is something that all of you as infection control practitioners will know and understand, which is the workflow and the ventilation, and then the recommendations that we make. And I've divided these into 3. It's the patient, staff, and the infrastructure and the environment. And of course, the role of infection control and what you as infection control practitioners and epidemiologists and people working in the clinical arena can do. And this is really a very clinical presentation, which I hope you will take it in the way it's meant to be delivered. So many of you know what an operating theater looks like, but just to remind you, this is an operating theater with conventional ventilation. I hope you can see my pointer. Yeah. Okay. So what basically happens is that there's a duct running through, which is a big air handling unit in the back somewhere, with a long duct which is closed, and it comes all the way down and it delivers air from the top, which is the influx. And this air is then turbulates inside, and I'll explain that to you in a minute. And of course, then leaks out through the various sites, like between the doors, the windows, at the bottom, the baffles, and so on. So this is the conventional theater ventilation system. It's not the one that many people see in Africa, that we see in Africa, which is the air conditioning. This is not the air conditioning system. This is a positive pressure delivery system. Now, from an infection control point of view, there is a very clear relationship between the patient, the healthcare worker, and the equipment. And all this comes together at the operating table. And the role of infection control is to protect the point of care, which is the incision site. So you protect the point of care in various different ways. And of course, this is the one that we're going to have to try our best to work with. But in a conventional sense, this is fine. But when we're looking at COVID, there is the patient and the healthcare worker that we also have to deal with. And I will address that too. So I'm sure many of you have been inside an operating theater, but this is what it basically generally looks like. There's a main corridor out here. There's an exit bay or an entry bay. There's a scrub room. There's an anesthetic room, and there's a preparation area for sterile services and laying up of trolleys and so on. And the surgeon and the anesthetist here, and this is dirty utility. And that relationship of point of care. So this is the anesthetist, the scrub unit, sorry, the scrub team and the surgeon, and they will come through there. So the scrub team will come through the scrub area here to this operating table. The anesthetist will come to the anesthetic area with the patient and come through this area. The patient will come through here, and or might even come to the anesthetic room, depending, but will leave through here, okay? And that patient will come here. Then you have the equipment, the clean, sterile equipment, which comes in through here, and it all comes together here. And this is then removed from here to the dirty utility, as you can see, with the blue line, I hope. And this is the point of care, this area here. So the whole concept of operating theaters is to protect this point here, okay? And the reason for that is this, that because is this the wound site? The person that's breathing or moving around or doing whatever they're up to, this can actually go over here and contaminate the table that's laid with the instruments. The people can do the same, but they can also, the movement around the operating theater affects the wound site itself. And this is why the ventilation that is supplied to the operating theater comes through in key ways to provide filtered efficiency, air movement, which is away from the wound site. The quality of air supply is excellent. The rate of mixing and dilution is very necessary. And of course, it is then removed through pressure differentials from the bottom. Somebody's microphone is on. Could I please ask you to mute your microphone? I don't know whose microphone is on. Sorry, excuse me. Can we please ask you to mute your microphone? Sorry. Sorry, could you please mute your microphone? Thank you. Okay, so the IPC here is the measure to protect the incision site, which I've repeated myself 3 times. But this is achieved by producing positive pressure ventilation. And this is where the dilemmas start. We're giving you clean delivery of good quality air, 24 air changes an hour, and the air movement will be away and turbulent, away from the wound site, getting a rate of dilution, but this is positive pressure ventilation. And this is delivered because the sources of infection in surgery, in surgical sites, are usually endogenous mainly or exogenous. There can be some airborne, and it's the airborne that we deal with ventilation. And it is assumed that about 70% of airborne contamination will end up land on exposed instruments. And therefore, it's not the operating theater which is the essential place. It's the layup room, which is the most essential place to have the highest rate of air changes. Even though sometimes with large operations, okay, there's a problem and keyhole is much less, but operating theater, the layup room is the most important. So just taking you through that carefully, the most air changes will be delivered to the layup room, which will then blow into the theater, and this is the clean area. And this is the big thing I've seen in many African hospitals. The layup area is like a kitchen, or it's like an open place where people leave their handbags. They've got kettles boiling there. They've got some instruments lying around. People come and meet their family, have lunch there. That is not what it's about. It is the most sterile part of an operating theater. The air will then move into the operating theater and under positive pressure, and then will go out from there to the peripheral areas. So the cleanest part of the operating theater is the preparation room, which is used for instruments. It moves towards the operating theater, it will leak into the surrounding areas, and finally go out to the disposal or the dirty area. In the prep area, we want up to 35 air changes an hour. And in the conventional theaters, we want at least 20 to 24 air changes an hour. Now, this is really, really important, okay? Now, here comes the dilemma. Let me go back, yeah. We need positive pressure in the operating theater. We need the air supply to be turbulent so it lifts off all the bacteria and the skin scales and so on, and gets rid of them in various ways. We need clearance of bacteria from the wound site, which is a very low risk to start. And we need that if air conditioners are used, that these have no major effect on recycled air, because that is what many operating theaters have in Africa. They have an air conditioner. It's not filtered. It's just cool. It's just for comfort. And there's no means of changing the positive pressure system into a negative pressure system, which is very, very important. Now, the dilemma now comes up with your behavior and with changes is that we need, if you're going to be doing AGPs, we need to be doing negative pressure ventilation. We need to make sure that the air supply is minimally turbulent, not very turbulent at all. In fact, the less turbulence, the better. We have to clear the virus from the infecting staff or patient. And if air conditioning is used, we can't allow recycling of air because that is contaminated air. Even though people will be wearing PPE, it's very important to understand this. And therefore, you need to set up a way of extracting it out of the operating theater to the outside atmosphere. And of course, the staff themselves have to be prepped in a very complicated way and in designated areas. I will leave this on, but I will ignore the side here because here it just tells you about the pressure conversions. But what it tells you is that in summary, the whole of the COVID story is to reverse what we know about conventional operating theaters. I will repeat myself and summarize by saying negative pressure ventilation, air flows to the outside, not the corridor. And of course, doors have to be kept all the time, must kept closed. And the one big problem that we know with the COVID, with the SSI bundle, is the constant opening and closing of doors keeps changing the way the air flows inside the operating theater. So somebody opens the door and says, would you like a sandwich? That actually changes the way air flows. So if you're going to try and contain what you're doing and do it properly, the doors must always remain closed. Okay. So the challenges here would be that, again, you're looking at ventilation with mounted cannot be possible. Changing negative to positive is not possible, but you can put an extractor fan. You can increase the air changes from 24 to 30. You can check airflow direction and you can try and exhaust it away from the corridors to the outside. And you can definitely stop this door opening and closing. So the minute the last person comes in, you lock the door. Staff protocols for the normal would be routine. You work through the scrub area, you come into your work area, a normal number of staff, the runners, and so on and so forth. It's usually this door that keeps opening and closing all the time. And we have to be careful of that. It's routine waste management, linen management, and so on. In a COVID situation, this is something that I picked up from one of the journals, and it is, I must admit, very much for a high-income country. It's not what we normally would be able to do, but we can get some ideas from it. So they've laid out their COVID by an entry corridor, and there's an exit corridor. So they're using the Ebola system, more or less, which I think is a little bit over the top for me, but I would not do that. Okay. You enter, and they say you enter and you put on one set of PPE, then you go into an anteroom, and then you put on another set of PPE, then you go into the operating theater, and then you do your thing there. and then you leave your first set of PPE in the operating theater, then you go to the exit area, you remove your other PPE with a buddy. So it all sounds like Ebola. And then you're going to have a shower. And I personally think that this is just too over the top. And I think there's no evidence to my mind for all this stuff. Okay. What we can do is we can have a designated operating theater, not difficult to do. We can have designated routes, not difficult to do. We can have a designated donning and doffing area. It's not difficult to do. We can increase the waste disposal because there's so much PPE being dumped all the time, so much that we have to increase the way we handle waste and increase linen supply. We must have highly trained, minimal number of staff. And this is absolutely essential and vital. Your staff must be the 5 or the 6 who are highly trained, and they will deal with all COVID patients, and that is the end of it. And the reason for that is because they get to know the system well. Minimal AGPs, and of course, single-use ventilator tubing, because now we know in certain publications that the incidence of ventilator-associated pneumonia has skyrocketed during COVID because people use so many tubes, and also because they weren't using them properly and they were recycling them and shortage of tubing. Other recommendation for the patient is that if you can help it, please do not have anything but emergency cases. You test all patients prior to operation, certainly in South Africa and many countries that is going on. It's still no guarantee because sometimes they are negative, but they might be asymptomatic or pre-symptomatic, so they're not got enough virus there. But, you know, at least it's a test. Place a surgical mask on the patient, as you can see in this picture, and you need to obviously monitor oxygen saturation. That's fine. This is an algorithm of precautions where you develop a decision tree. And I would just urge you to have a look at this. It will be in the slides. You can look at it. You do the urgency of the operation, yes or no. This is a tick list. Anticipated burden viral load, yes or no, high, low, whatever. Opportunity of aerosolized virus. Now, this is where you're going to be doing intubation, extubation, and all that sort of stuff, suctioning and stuff. Patient symptom testing, then you prioritize your patient, you conserve your PPE, and you protect your members of staff in the operating theater. So the operating team itself, okay, have got to be looked after. And the staff is a minimum. That is why you need to have them highly trained. There's a surgeon, assistant surgeon, scrub nurse, runner, anesthetist. This is possible in Africa. There's nothing wrong with doing that, okay. You ensure that all of them are immune and healthy. They will probably be exhausted by this time, but okay, we give them support. Daily temperature checks, and we investigate any type of respiratory illness by doing a PCR, and then we track and trace. Now, in some areas, they have this, which is a designated coming and going, which I mentioned to you. You can have it if you like, you don't need it really, but you do need a designated area for where you're going to don and doff because of the amount of PPE that is going to be generated. Okay, so just keep sure, you just make sure that the way you take off your PPE, that there is sufficient support for cleaning, disinfection, disposal and so on of your equipment. The staff in the OT, we've already mentioned this, and they will be working in theater wearing respirators. This is the one place that I will not argue against anybody who says they need a respirator when they're working there. Anybody, because don't forget the ventilation is under positive pressure and we can't change it to negative pressure. We can exhaust it, but we can't change it. It's best and most safe if we can actually wear respirators. And the surgeons and anesthetists will obviously wear face shields or protective eye goggles, okay? The change to the protocol will require that all equipment is covered in plastic and that all areas are cleaned, recommended disinfectant that we use. You allow time to dry before the next case. You don't have to do this case last, but if you must, then that's fine too. You remove all the infectious waste and normally labeled red bags, okay? This is just a rapid algorithm showing that if there's an urgent patient, you do a rapid test. If they're positive, then they consider whether you want to give non-surgical treatment, rest and so on. If they're negative, then off you go, PPE and all that, and you go off and you do the operation. If it's a scheduled patient, not deferrable, you can't get rid of the person, then you do a rapid test, you do a PCR, a quick rapid PCR. Well, we don't have rapid ones, but anyway. If it's positive, you go and do it. If they're negative, then you can actually put them through. If you cannot postpone the surgery on a COVID positive person, you really have to make sure that you're well protected during this and that aerosolization is minimized. This is a very complicated slide, which I really don't want to go into great detail, but it gives you a very good layout. And since it's going to be in the in my slides, you can have a look at it. And basically, it talks about patients from the isolation ward, the prep area, the nurse in charge, what she does, how you activate the team and you transfer the person, what the runner does. You place infection control tags on the doors and show the corridor, place PP in the trolley, make the surface disinfectant available. You wait to receive the transfer patient. Good. Then the nurses in the operating theater wear PP, they prepare themselves, scrub nurse ready for surgery, and then you get yourselves organized. The anesthetist and so on, they check the respirator, and they probably will need disposable ventilator tubing, and they get the medication ready, and the tray is ready, and the technician is wearing full PPE again to assist the patient, and they don't enter during induction. So this is a really important point, that while the anesthetist is inducing, you really shouldn't be popping in and out, asking if they want a sandwich or shall they get them some tea or whatever. Just keep that door locked. Inter-operator phase, you circulate outside the OR to provide material and so on. And then you contact the runner if anything is required. So it is quite a tight, closed space that we're functioning in. Obviously, minimal number of staff are required. And post-operative phase, you can recover in the operating theater and you transfer the person back to the isolation area. Now, this is a difficult one because if they've had an invasive surgery or any other surgery, you really need to be there to make sure they don't have some mishap during the recovery period. So an area has to be designated for COVID patients in the COVID ward, in the COVID hospital, where recovery can take place separate from the other side in case you need to carry out suction or do support or whatever else, okay? Now, for some reason, this group also say everybody should go and shower after the procedure. I'm really not sure why, but I suppose if you've got a shower in the place, you might as well use it. And that is perfectly fine. These are some guidelines I'd refer you to. Obviously, the global guidelines on surgical site infection, which I had the great privilege of being part of. The decontamination one for the WHO, which I also had the great privilege of not only being part of, but also chaired. Solutions that we're looking at. The best practice protocol has just come out. You please need to look at that. And COVID in an operating room, there was a review of evolving safety protocols, which I really enjoyed reading, and I thought I'd put it up here for you. So on that happy note, and this is our guideline from South Africa, which we are in the process of updating at the moment. Very quickly, dealing with medical devices, perfectly normal. You don't have to do anything exceptional. There's no change to the reprocessing methods for surgical devices if you've got a good system in place for sterile services. Only the bit that I said previously about covering the plastic and looking at what's going on. So if I summarize very quickly in this 2 minutes, modification to the existing OT is going to be expensive and difficult. You could possibly put in, if you can, a dedicated operating theater. Try and install extraction fans if they've got an outside ward, and you can increase the ventilation if you possibly can. You've got mechanical ventilation. Patient behavior for handling patients, you have to test them. All patients should wear surgical masks during the operation. That's not something that we do. Modify behavior of staff is you check, temperature check, minimal number of staff involved. We improve the PPE, okay, in the sense that we use better PPE, most likely respiratory respirators are very important. I'm not really worried about the head and the foot covering and all that stuff. I'm more worried about your eyes, your nose, your mouth, and your hands. So make sure that that works well. Understand donning and doffing. And the reason I say that is because if you don't understand it, you're going to run into trouble of contaminating yourself. And constant hand hygiene, of course, which goes without saying. You minimize talking, movement, and contact in the OT. And if you are going to share a restroom or a tea room, please make sure that you have safe distance between you. Okay. I will stop sharing there, and I am quite happy to answer any questions, should there be any. Is there a chair?
Yes, there is. Thank you so much, Prof, for that concise and very informative presentation, which touched on pivotal challenges that are faced in the operating theatres in the African context. So if you've got any questions in relation to the presentation that was just given by Prof, please put it in the Q&A and she will address it after all the presentations are done. Thank you. So at this juncture, I would like to present our next speaker. Our next speaker is Ms. Chipo Gwaya, who is with the Infection Control Africa. Oh, sorry. Okay, I'd like to present Ms. Chipo Gwaya, who is with ICAZ, which is Infection Control Association of Zimbabwe. She is an infection control specialist with 15 years experience and also was a coordinator in one of the leading private hospitals in Zimbabwe. She's also currently the secretary for ICAZ, chairperson for ICAZ training committee, and senior infection prevention and control trainer with RTSL Zimbabwe. Her qualifications are she has got a master's in infection control and also postgraduate diploma in infection control acquired from the Stellenbosch University. She's also an intensive coronary care nurse and also a registered general nurse. Chip will be presenting on achieving the ideal layout for specialized units, looking at the ICU and emergency units as well. Over to you, Chipo.
Very good morning to you all. Good morning, good afternoon, depending from where you are. Next slide. We're talking to you about the layout and flow in specialized units, the ideal and how to move to get it right. The objectives of this presentation is to define specialized units, describe the layout of specialized areas, described by PC consideration, and explain the flow of staff and patients. Next slide. For the introduction, various special care areas exist in many healthcare facilities, and these include adult and pediatric ICUs, theaters and surgical units, oncology departments, and infectious disease units. Specialized care units are purpose-built, and the layout is organized to minimize risk of infections to patients, healthcare workers, and visitors. Work practices and processes are also tailor-made to enforce key IPC practices in order to protect patients and staff and visitors. An example of a specialized, I want to give a definition of what a specialized unit is. A specialized unit is a unit with specialized equipment, medical and nursing staff. It is designed in a specialized manner, mainly considering the healthcare worker and the patient's safety. Examples of specialized units are intensive care unit, maternity, renal unit, infectious disease unit, and also include our isolation centers for COVID and any other infectious disease. Also, another specialized unit from the previous speaker is the operating theaters. Next slide. Layout of specialized units. Specialized units should be laid out in a layout of the different departments, units, wards in relation to each other will determine how staff and patient move within the facilities, and also the number of patients within the facility and the type of equipment that can be accommodated. So we also need to have our engineering and our administrative controls to be well established in order to have effective implementation of IPC measures. So for our administrative controls, these involve how the actual healthcare worker activities are going to be done. That's our work process. And this is how they conduct their day-to-day activities. Administrative control should lead to work policies or procedures that are aimed to reduce or minimize exposure to a hazard. So they should have defined policies and procedures of how activities are done to reduce risk of infection. And also have administrative controls for COVID-19. For COVID-19, example of administrative controls to be in place is updated training of healthcare workers for COVID-19, the risk factors, protective behaviors, for example, the hand hygiene, rational use of PPE, the donning and doffing, and also proper disposal of their wastes. They have to also include establishing screening and triaging points for all stakeholders, especially on their entrances, enforcing safe behaviors, that's our standard precaution, and having reminders in the workplace. That is our IEC materials for everyone to see, having psychological support to address healthcare workers' anxiety, same factors, and provide enhanced medical monitoring health workers during the outbreak. So the engineering controls, these focus mainly on the infrastructure. The layout of different departments, units, and wards in relation to each other determines how staff, patients, and other services are provided, especially waste management, linen management, and food services, how they move within the facilities. It's important. The number of patients and type of equipment that can be accommodated, the availability of sufficient hand hygiene station, both hand washing, hand sanitizing for both patients and visitors. The ventilation system of the facility, whether it's mechanical or natural. All these things have to be put in consideration when laying out a specialized unit. Next slide. Let's talk about isolation units. Isolation units are built depending on the disease burden of infectious disease in that country. So most of the countries, like for example, Zimbabwe, had infectious disease hospitals in each city, but they had very few beds, and normally we did not have lots of these infectious diseases. For COVID-19 pandemic, existing facilities have been repurposed to become isolation facilities, and new structures, temporal or permanent, have been established to facilitate triaging of suspected and confirmed cases for COVID-19. Next slide. So for these, IPC considerations have to be put in place. So when building or renovating, you have to consider space for the following: clinical space, where clinical activities are going to take place. That space has to be in place. Our hand hygiene facilities in the patient care areas, that's our hand washing facilities, and our hand sanitizing facilities have to be put in place. The reprocessing of medical devices, that's where our decontamination will be taking place, has to be there in the isolation areas as well. The staff areas, tea rooms, restroom, and conference rooms have to be included in separate space. For ancillary staff is also to be included. Clean and dirty areas for medicine preparations have to be in place, and also the sluice for waste holding areas and also for sluicing of linen should also be in place in these isolation areas. Slide. As we continue with our IPC consideration for our isolation areas, they should have a good ventilation, that is 12 to 15 air changes. And this should be negative pressure, or if we cannot afford the negative pressure ventilation, well, you can have the natural ventilation, but natural ventilation is difficult to achieve 12 to 15 air changes. The types of the floors, lighting and other furnishings, has to be put in place. The patient's comfort has to be considered, type of beds which the patients are going to lie on, and also the patients should also have entertainment in those isolation areas. Separate toilets for staff and patients. Patients and staff should not mix. patients should have their own toilets and staff their own toilets. Also, isolation areas should have single rooms where toilets are in suite or cohort facilities where they will be sharing toilets. And also it is important to have storage areas for personal protective equipment and sterile items, drugs, and also linen, and also for cleaning supplies. Next slide. So how did we move from what we have and to what needs to be there? So moving from what you have to where you need to be. Next slide. Involvement of infection prevention and control practitioners is important because architects and engineers, they know how to plan these, but they don't have enough ideas on where to put things, and sometimes without IPC practitioners, you might find things not well done. So because existing facilities have been repurposed to become isolation facilities and new ones established to manage COVID-19 patients, it is important to actively involve IPC practitioners, experts when constructing these isolation centers, or when repurposing healthcare facilities, in order to make sure that the infrastructure will support good infection prevention and control practices. Next slide. So this is an example of a unit before repurposing. Most of our wards, they look like this, where we have the wards with patients, beds, and the nursing station, toilets, storerooms, and sluice rooms. So these were the ones which were repurposed or renovated to suit COVID-19 patients' care areas. Next slide. So this is an example of a repurposed unit, the layout and the design of an isolation unit to be more like an isolation unit. We now have as a ward or an intensive care unit where we have the entrance of staff, the toilets, now donning and donning area, and patients, the staff goes in, nursing station to the ward. And we have the storeroom, another storage area for either linen and any other things. And we have a sluice room there where we can sluice and put our waste, store our waste, then the exit for doffing, and then the doffing area. So this exit, this is where waste and other things can also exit. Next slide. So ideally, the layout of these isolation units should look like this. What is being presented in this slide, whereby we have a male toilet and a female toilet, a donning area for staff, and then the storage area for personal protective equipment, the corridor where the staff walks through to the isolation ward, and also we have an exit when patients are being discharged, where they go out through, or if they die, they will also go exit through that exit. So the exit of staff and the exit of patients is totally different. So patients, staff, when they want to exit, they will go through the sluice room to the doffing area where they will remove their PPE, their toilets for helping themselves. Then after that, they will shower and then they will exit. So this is an ideal layout of an isolation ward or an isolation center. Next slide. So now let's talk about the staff and the patient's flow. The movement of staff and patients in the isolation treatment area should be controlled, and it has to be unidirectional. There shouldn't be a mix-up of things, patients coming and staff coming in one direction. So we have low risk area, we call it the green zone, and we have an intermediate risk area, which is called the yellow zone, and the high risk area, which is called the red zone. Staff areas are low risk areas, and direct movement from high risk areas is prohibited. As you can see in the picture there, that the high risk, where the red color is, in the low risk zone, the green, and the yellow for the intermediate risk. So we also need to have doffing areas which are separate from the donning areas. As the donning area is the green zone, it's a clean area, and the doffing area is the dirty zone, which will be also like the red zone. Next slide. So in summary, what are we saying? We are saying we have to involve infection prevention and control practitioners before laying out or designing or repurposing space for any specialized units. We also need to repurpose and ensure areas conform to our infection prevention and control standards that can be possible in the low or the middle income settings, not to worry ourselves with the high income countries, because sometimes we won't have enough things to suit the high income countries. So we need to repurpose our facilities so that they conform to possible IP standards in low to middle income settings. Next slide. Thank you. If there are any questions, you can ask now. Thank you very much.
Thank you so much for that comprehensive presentation, Chipo, which was looking at infection control in specialty areas, looking at setups, ideal setups, and also looking at patient and staff movement. At this juncture, we are going to move to the Q&A session, and I would like to introduce Dr. Yewande, who will handle the Q&A session. So for all questions that you do have, please put them in the Q&A box. And there are a lot of questions as well around the presentations being forwarded to staff. Please note that all these presentations are recorded, and if you're registered, they will be sent to you via email. Thank you. Over to you, Dr. Yewande.
Thank you very much, Non, for that. And thank you to speakers, Chim, Prof. Shine, and Chipo for the very informative sessions. We will now move to our question and answers session. I see that Prof. Shine has started to answer some of the questions by putting in a reply. But I see many more questions are coming in for Prof and for Chipo. So please keep your questions coming, put them on the Q&A chat. Today on my panel, I have representatives from ICANN, from Africa CDC, from US CDC, on the call, who would also be available to answer some of your questions. So I think we'll start with you, Prof. I see there's a question you would like to answer live. This question has come from our colleague from Ethiopia, and it's about Operation Theater precautions. And the question is, in areas where rapid COVID tests are not available, should we proceed in emergency surgical conditions such as trauma? Is there any protocol in case of mass casualty, for example, and you have to manage a mass casualty in your operation room? What are the COVID preventions that they can take? Over to you, Prof.
Thank you. I think it's a really good question, and it's a very practical question. You know, it's all good and fine for us to be talking through a webinar, but what does it really mean when you're out there? If we don't have facilities to test, we will assume that everybody that we are going to bring to the operating theater is positive. Okay, so that's that. Whether they can breathe or not breathe, or whether we need to do anything to them, that's it. I would imagine when you're talking about mass casualties, you're looking at a war area, or you're looking at some sort of trauma situation where there's an accident, an MVA or something, motor vehicle accident or similar. So that means that you again have got to assume that everybody is sorry, has got COVID. So one of the things I said was that the staff should be wearing respirators and a face shield. And I think that is the way to go forward. I'm not saying it's going to work as beautifully as you want it to, but if you can increase the ventilation in any which way, that will be fantastic. That will really help. But the basics would be that you increase the ventilation, try and extract as much as you can, make sure that you protect yourself with your nose, mouth, and eyes and hands. And then if possible, if the patient can bear it, then put a mask on the patient. If I may, please, one day, there's one question that has come up frequently on several occasions, and that is, what happens when the masked patient comes into the operating theater? You've got to take the mask off because you're going to intubate the patient, you know. So, and many times that is a time when you are doing a lot of aerosol generating procedures. The one thing that we have seen, which is quite useful, is a very short sheet. It's a plastic sheet, which has got a hole here. So when you intubate the patient, it actually goes through that. And they also use it for bronchoscopy and endoscopies. So it's just a plastic sheet and a hole through it so that it reduces the amount of secretion and reduces the amount of aerosol that are generated. I have not read any papers or seen any evidence onto how effective it is, I must say, but I have seen it being recommended by certain organizations. I don't know if that helps, but it's a really difficult position. And you know, when you've got an emergency, you can't do anything about it. Thank you. I hope that helps one day.
Yeah, it does. And that is really a fantastic question because sometimes life just, things happen and there's no textbook or protocol to do this. So I think I like the ideas that you've shared, which are very innovative. And I hope that our colleagues have benefited from it. So the next question is directed to you, Chipo. Yes, thanks so much, Prof. Chipo, this question is directed to you, and I see Prof also wants to answer this. So I'll go with Chipo first, then Prof, you can answer this. How can we use PPE rationally, thinking around things like gowns and gloves? So that question, Chipo, if you want to take a stab at it, then Prof would wrap up that question. Thank you.
Thank you, Dr. Yaonde. PPE can be used rationally when depending on the activities you want to do. So the activities you want to do within the healthcare facility determines what type of PPE you are going to put on. Not all PPE is worn without any activity you want to do in the healthcare facility or in the ward. Thank you. Maybe Prof. Shaheen can add.
No, I have nothing more to add. I think that simply it's been well defined as to what we are going to use. And I think, I just want to say something. I've looked now and found about 16 different protocols for COVID-19, because while I was preparing for this talk, they all say more or less the same thing, but with a little bit of modification. So I personally think that we need to be very clear about the guidelines that we're going to use and for the PPE and so on. And we should stick to it rather than changing it because somebody else is doing something slightly different. I don't know if that helps at all, but that's my take on it. Thanks.
Thanks, Prof. And I will probably, after this question, I'll give you a break, then I'll move to my other panelists just so you can catch your breath. But when I was doing a quick scan, I see a lot of people asking questions around negative pressure, and there's this one I think you've answered, but the person wants further clarity on how to achieve the pressures. So yes.
It's a complex business, and without sort of beating our own drum, I think it's worthwhile that those of you that want to understand the built environment and IPC should have really attended a course on infection control to explain it to you. But basically, The thing about negative pressure is that the air leaks inwards into the room. So in order for the air to come into the room, you have to extract it. And when you extract it using an extractor fan on the wall or some other method, the air can only come into the room because the air from the corridor will come in. The room is then considered to be under negative pressure, okay? And that will be pulling up. In the operating theater, we have positive pressure. So we're delivering air into the room and it is full of air and then it gradually leaks outward. So the thing about negative pressure is for airborne precautions, obviously, and so that even if you open the door, the pressure should be such that you do not get a change of airflow. It's not easy, it's really difficult. So negative pressure leaks inwards and positive pressure leaks outwards. If you can just, simplest way for me to put it to you, I'm afraid, okay?
Thank you so much, Prof. I hope that really answers your question, Humphrey. Chipo, this question is for you. And of course, the panelists, thanks you for your presentation, but it's around what type of floors is really recommended in view of the COVID pandemic. So what type of floors, I guess, in the hospital settings is recommended? I think that's the person's question. Over to you, Chipo.
Thank you, Doc. Types of floors which are recommended in the healthcare settings, also in the COVID centers, are continuous flows, especially the veneer one is the continuous flow which is recommended. The tiled floors are not recommended because they have gaps in between which harbor infections. So those ones are not recommended, but the continuous ones like the veneer type of flow is recommended. Thank you, and over.
Thank you very much. So I think I'm seeing a bit of a theme around tuberculosis patients and COVID patients. So I think what I would try to do is throw this to the panel. I can see Prof. Valerie and Prof. Shade are also on the call, and Elizabeth from USCDC is also on the call. So one of the questions is around what is our advice when it comes to treating TB patients and COVID-19 patients in the same infectious disease unit in a day hospital setting. So what is the sort of guidance that we can give them? I guess, again, that would have to, we will talk about things like the required PPE and things like that. Prof. Shade or Prof. Valerie, do you want to take a stab at it?
I was hoping Shade would reply. My voice is not great today. But I know for one of the problems in our healthcare environment with the COVID pandemic is that many of our routine activities have been put aside. So TB clinics have been reduced. A lot of these patients in our environment anyway, are referred to primary health care. So if they're receiving routine treatment, that would be done in a primary health care treatment. But you have to assume that a COVID patient can acquire TB and a TB patient can acquire COVID. So really you need to have procedures, administrative controls, and your ventilation that will take this into account. So with TB patients in the ear, we've always said that you have to triage TB patients. You want to separate out the coughing patient. But now you have an additional factor of COVID patients who are coming in as well. So as much as possible, I'm not sure this is really an adequate answer because I haven't thought it through properly. But you need to try and separate. So you need to make sure your TB patients our triage to make sure that they don't also have an additional respiratory infection on top of their TB.
Fantastic. Thank you so much, Prof. Valerie. I don't know if Prof. Shade has unmuted herself and she's ready to take this, or if Shine would like to take it before we move to the next round of questions. Okay. So we move to Chipo. We have a question for you. It's around is there a possibility of infection transmission if the exit from the ward will still connect to the nursing station? So I think Chipo, you must have mentioned something around that, and there's a question on that for you.
Thank you, Doc. The exit of the patients in the nursing station there is no problem with having a nursing station nearer to the exit of the patients, because these patients are now no longer infectious and they are going home. So their exit is okay if it is nearer to the nursing station. There's no way they can bring in some the microorganisms to the nursing station when they are exiting. And also the exit of people now shouldn't be nearer to the air, because now the nursing station is the low risk area, and the people are coming from the highest risk where they have their PPEs and everything. So they will be going out now. The exit should be away from the nursing station. That's what I think is. So if anyone can assist, it's okay. Thank you. Over.
Thank you so much for that, Chipo. Thank you for that response. I think I'll move. There are a few questions popping up for Prof. Shine. Please keep your questions coming. Prof, I think you must have mentioned something around healthcare workers or staff members being in good health and having to do some tests. But this question, which is like a two-in-one, is I think our colleague Daniel wants to know, how often should healthcare workers or staff members be tested? I mean, that's the question, and it's directed to you.
Right, so thank you. I think I just want to clarify what I mean is that every day when they come in, they should have a screen. So they must be, they have the temperature taken and symptoms and so on and so forth for everybody who comes in, okay? But if in some healthcare facilities, particularly where they have dedicated COVID wards or hospitals, or where they're going to do dedicated surgery, and they have been known to be in contact with a case of COVID in a high transmission area, then they are usually tested either once a week or once a fortnight. Or if anybody around them has been unwell, or in fact, if they feel that the person could have been exposed. Okay. Now we do know that our exposure, certainly in South Africa, has come out, and certainly other parts of the world as well, that 80% of transmission has taken place at home. It takes place in the social environment because everybody's relaxed and they've left their, there are no masks and they relax. About 10% takes place in the tea room because it's a closed environment. Again, your mask is off and you're not behaving, you're just relaxing and sharing food and sharing, phones or whatever else. So the patient to healthcare worker transmission is actually documented as less than 4% globally, okay, which is really interesting. So that's not where it's coming from. However, if there's an AGP, the chances are that will go up to maybe 5 or 6%. It's still, because of the protection, is very effective indeed. So I just think that you need to remember that. The reason that people have to be in good state of immunity is because they are working long hours and they are really, really tired. And I can assure you, this is from my personal experience, that I've seen people passing out, healthy young people, because they've just been working for so many hours. So it's really important to understand that the immune level and the status of the person is good. And of course, the vaccination. As soon as you get a batch of vaccine in your country, you should make sure that all frontline workers are vaccinated as soon as possible. And I would advise that quite strongly. I hope that answers your question.
Thanks so much, Prof. I think, yes, it's something that we are all campaigning for. Our frontline workers are really the heart of the situation, and we must keep them protected. And now that we are starting to see vaccine rollout, we really encourage healthcare workers to show that leadership and show that commitment and protection, and start to go forward for their vaccination. So thanks, Prof. It's really important we keep our healthcare workers safe. So we encourage everyone on the call, if vaccines are being given out in your countries, please be sure to get in line and get vaccinated. Thanks, Prof. Elizabeth, I think I'll throw this question to you. Is on, I think, a question, and I would really like other panelists to also share their opinions and views about this. Is the recommended number of, okay, so this question is a bit confusing, but I think the person wants to know what staff do we recommend to ideally change their PPE, and what's the recommended number of times they need to do that. So I think I'll try to break down the question so we cover every possible way this question could go. Is like, for example, gloves. What is our recommendations when we, people that are seeing patients, how often they need to do that? I think we need to reiterate these things every now and again. Face coverings or gowns, for example. So Elizabeth, I'll let you start off, then I'll go back to Prof, then move to the next question.
Okay, thanks, Wande. And before I start answering that question, I want to circle back a little bit to the question before about how often staff should be tested. I think we just want to really reiterate some principles about testing, which is there's no reason to keep testing a lot of staff or all staff willy-nilly all the time. There's no reason to be on a regular testing schedule unless you are on some high-risk ward. And really, you should think about testing, using it judiciously for people who are at high risk of potentially having the disease. Those would be people who are exposed to COVID patients or people who come in symptomatically. You know, what Prof. Shaheen was saying, when you're coming into the, everyone should be screened at least for symptoms coming into the hospital. And if you have symptoms compatible with COVID, certainly the first thing you should be done is told to go home, or, you know, get first evaluated by occupational health or evaluated by somebody at the hospital, tested if necessary, and then told to go home so as not to infect either others, patients, or, as Shaheen brings up, very importantly, not to infect other healthcare workers in tea break rooms or situations like that, where you might let down your guard, take off a mask, you think you're safe. The other healthcare workers think they're safe around healthcare workers, and then you spread the disease. But really, testing should be thoughtful and should be really based on situational awareness of when somebody is at high risk for getting disease, but maybe asymptomatic or actually has symptoms. But other than that, there's no real recommendations for regular testing, especially for people who are not at high risk or don't have symptoms. Getting to the question, let's say, of gloves and how often people should change them. Let's again take a step back. I think one of the first things people need to think of is, do they actually need to use gloves in any given situation? I think sometimes we see people using gloves when good hand washing, good alcohol-based hand rub, good hand hygiene would be just as effective to help protect them as gloves, especially when touching intact skin, for example. If you are using gloves, you really should be changing them between each patient. If you're, if you're a direct hands-on healthcare worker, because there really is no good way of adequately like washing the gloves like you would your hand, or using alcohol-based hand rub on the gloves like you would using your hands. Your hands are in some ways much more practical than gloves in that you can easily wash them and disinfect your hand much more than you can with gloves. So you use the gloves for one patient, or if you're an environmental cleaner, you might be using the gloves, you're going from place to place and using the same set of gloves. that's all right, unless Prof. Shaheen says it's wrong, and then I will completely follow what she says. But that would be the most simple question I have about gloves. One is, do you even need to use them? Because it might be more practical to use just bare hands, properly cleaned and disinfected. And then two, if you do use them, change them between each patient. Over to the other speakers.
Over to you, Prof.
So we've covered gloves and well, I mean, we know that there has been a huge outcry about face covers. Just suffice it to say that in America, they have now moved to using respirators for all, I suppose because they can afford it. We've been doing surgical masks for everybody, apart from when they go for an AGP, which is the WHO recommendation. And I think we've managed to contain COVID quite well. So we don't have major big outbreaks and we haven't had any high mortality. So I think the system seems to be working quite efficiently. However, what we have found is that there is a reuse of, not a prolonged use, which is fine. That means one face cover per person is carried on, like the respirator is carried on for the same person, for like they do for TB. But this is different. This is where they are reusing by doing things like microwaving it or boiling it or wiping it with alcohol or trying to do things. That destroys the integrity. So I think we have to be very careful that we don't do that. And, you know, it sort of takes me back to ideas where people think that a disinfectant is equal to a panacea of everything, that they soak that mask there. I've seen this happening in one place where they soak the respirator in a bucket of 0.5% chlorine and thought that, you know, when this thing comes out, it's going to be sterile. But it's actually totally destroyed the integrity of the mask. And I think we've done this already in one of the previous webinars. I really am not interested in whether you cover your feet or your head. It's got nothing to do with COVID. It has to do with the dressing up and a fashion show and to show people that you are really important. As far as your body is concerned, you can wear a cotton gown with a plastic apron, which is reusable, which is fine. I mean, the cotton gown is reusable. The plastic apron is cheap and can be thrown away. If you want to look like everybody on television and wear those disposable big gowns that they're wearing all over Asia and America, that's entirely up to you. It makes no difference to the outcome of COVID. Double gloving makes no difference to the outcome of COVID. And I strongly recommend that you go back and reread the WHO recommendations on healthcare workers, which is either just coming out or it has already just come out, literally within the last week or so, okay? So there is, it's all in there. Have another look. And maybe we could, from ICANN side, we will talk about it, where we can actually do summaries of some of these big documents and put them up on our website for you guys to go and have a look at the condensed guidelines or summarized guidelines that we would like to see happening. I hope that helps. Thank you.
Fantastic. Thanks very much for that. Thanks, Elizabeth. I see there's a question, Prof, you would like to answer, and that's the question around, in Africa, most health facilities were constructed without taking into account a standard isolation unit and no finances to upgrade. What is the best way to design a temporary isolation unit, and what materials to use?
You know, that's such an amazing question. It's a really, really important question. You know, we're stuck with this block of cement, and now what do we do? So I would think, and I think it's really to do with what you want to achieve. So there are three things we want to achieve. We want to achieve that a group of people who are infected with the respiratory virus are isolated from the rest of the people who didn't expect to get the virus when they came into hospital for whatever reason, like either cardiac or so you need a separate area. How you define that area is quite simple, in that you can even do like a tent, and a lot of places have done that. You can have like a tent, which is an isolation area, or 4 walls. All you need for isolation is 4 walls and a roof, really, to be honest, okay? Then you have to add the ventilation, which is the negative pressure ventilation, which is drawing out, and if you're very luxurious, you want a separate toilet and a bathroom. You can't always get that. I understand that. Okay. So at the very basic level of isolation, I would suggest 4 walls, a ceiling of some description, and extraction. And of course, you'd keep your PPE on the door outside, and so that you put it on when you come in, and then you take it off before you leave. I don't know if that helps. That's the simplest I can suggest. You know, I really think that we have to stop looking at the big fancy stuff. It's great. When you build a new building, you can go for the ensuite, negative pressure, blah, 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 this, that, and the other, up and down the corridor, anteroom, blah, blah, blah. Like we talk about and we teach with the FIPC and the International Postgraduate Diploma. We teach them about these things. But in a simple everyday working environment, that's not what happens. If you go to an MSF hospital, that's not what's happening. It's very simple, you know. Get ventilation into the place, get your PPE sorted out in a way that you don't contaminate yourself and everybody else, and get bed spacing between patients, and that's fine. I hope that helped.
Yeah, that is definitely helpful. Thank you so much, Prof. Shaheen, for that. I'm just trying to see, I see most of the questions we have already at least tried to take a stab at. I think this is an interesting question, which colleagues on the call and on the panel, it'll be interesting to know what your experiences are across your countries. This question has really come up a lot, and I think we have put out an advisory around the standardized qualities for masks, but this person wants to know that most masks that is being used by lay persons, for example, they're not of standardized qualities. So the question is, how effective are they? What's the variation in this type of mask, particularly the one, I think this person is referring particularly to cloth mask, because this is about tailors. So I imagine that that's the one they're sewing and reselling. So I think I'd like to hear everyone's opinion around what they're seeing in their various sort of settings and in their various countries. Over to you, Prof. You can kick it off.
I could perhaps kick off by telling you that before, on the 5th of March, we had our first case. From the 7th of March till the end of March, we did nothing but investigate the layers and layers of what we should be using on a cloth mask or a fabric mask. So is it 3 layers of cotton? Is it whatever? So what we landed up with ultimately is the government regulation that said you'd have 2 layers of cloth mask or of cotton with a layer of polypropylene spun bond inside. And the reason for that was because the entrapment, the inertia, all the dispersion, everything that we've talked about for masks and the cloth mask comes from this. So it's brilliant. It actually holds everything in and it's very good. We had then sent our masks for testing to the United States. And there was a study done by May Chu, who's an excellent person who works on respiratory programs. And she tested 16 masks from all over the place. Most of the masks, and the comparator was the surgical mask. So the guys from Israel and a couple of other countries from the United States and up all over the place, their masks were sitting at about 89 to 90%. The masks that we sent through were sitting at 70% filtration. And there's also 2 very good papers published that are showing that the more layers you put, the better your filtration. But the minimum filtration you'll get from 3 layers is about 50% or 60%. Now, I think this is really important because you really want to make sure that you've got as much filtration from source to outside and from outside and from on the other side as well, so that the amount of a droplet, if you like, or long range aerosol in the environment is reduced considerably, perhaps even enough not to cause infection. So there's a lot of work done on cloth masks. Sorry.
Thanks a lot, Prof. Colleagues on the call, Prof. Valerie, Paul, if you'd like to share your experience around the type of mask available, and if there's any advice for our colleagues on the call.
Okay, so we were very nervous about using cloth masks initially. But then a lot of publications, as Shahina's mentioned, came out about the effectiveness of cloth masks, particularly if you use the right kind of material. And we started off with 2-layer masks. So then we followed, in fact, from South Africa's experience, because they have a very good document on cloth masks, which we found very helpful. And also the WHO guidelines eventually came out about cloth masks, and we followed those. So we do recommend the 3-layer masks, and our numbers have really, we've had a first wave and a second wave, and certainly the second wave was due to people not adhering to recommendations. So they got very casual about wearing masks and social distancing. And then the government brought in another lockdown, and that reduced movement. But the cloth masks have been an important contributor, I think, in reducing transmission. And if you have one person wearing a cloth mask, then they, to a certain extent, protect other people. But if you have everybody wearing cloth masks, then it reduces transmission within that community. So I think they're important. I think they've been useful, particularly in an environment where people cannot afford surgical masks. So we've really, to a certain extent, not entirely restricted use of surgical masks in a healthcare environment. So that's my contribution.
Fantastic. Thank you so much, Prof. Valerie. Chipo, do you want to add anything? I see your mic is on. Do you want to add anything?
No, Doc, thank you.
Fantastic. So I think we will take one last question. Prof, I will throw at you. I know that there's been a lot of talk around air conditioning and COVID-19. So this question is just, can we use air conditioning in COVID-19 rooms? I'm guessing treatment rooms or isolation rooms. So that question is just very broad. What is our sort of guidance around using air conditioning with COVID-19 patients?
Well, the simple answer is no, because there's recycling of air, there's recirculation of air. If you've got a wall-mounted air conditioner, it's not filtered. It brings in some air from outside, about 5 to 7% air comes in every hour from outside, and the rest of it is recycled from inside. So the air comes down, it goes all the way down, it goes back up again, and it gets recycled. It's not filtered air. Then if you've got that situation, which would probably be in many hospitals where they have operating and so on and so forth, you have to then increase the space between, or the number of people occupying that space has got to be less than 50%, which is why we are saying in the operating theaters that you reduce the number of people inside to 5 for the scrub team and the surgeon and everybody else. And if you're in another environment, you reduce it to occupation of 50%. Then you go into the public health measures of wearing a mask, social distancing and hand hygiene and so on, and environmental cleaning, okay? So in essence, that air conditioner is there to make you feel more comfortable, but if it's not extracted, then you are recycling air, air with the virus in it, yeah? Obviously. So it's not the best thing to do. If you had a choice between an air conditioner and a window, I know which one I'd take. Probably go for the window. And they stay hot in some parts of the world, but you know, that it probably saved my life though. So I think that is, I would do that. So that's my idea, my opinion. Thank you.
Fantastic. Thank you so much, Prof, for that reply. I think we have done a good job trying to take on this very insightful, and it's been very interesting questions, I must say. Quite practical. I think that's what we're here for, beyond sort of the textbook way of doing things. on the field, how does it feel for you? And that's why we are here to answer to the best of our abilities, based on evidence, to give you guidance to navigate these very difficult situations that you might find yourself on the field. So I'd just like to say thank you so much to my speakers for today's session, and to everybody that was on the panelists. Thank you so much to our interpreters who are giving us simultaneous interpretation in Portuguese and Arabic. Thank you very much. And most importantly, thank you very much to participants who have stayed on this call and who have kept this session very interactive through their very interesting and quite insightful questions. So on that note, I say thank you very much, and I will see you all next week. Bye.
Thank you.
Thank you. Bye, everyone.